Bismillahirrahmanirrahim. Assalamu alaikum. So today we will be doing endocrinology, FAP recalls, and some of the task logs. Okay, so this is endocrinology, FAP recalls. And the question number one. This question is about Tanner stage. Okay, they say that a 13-year-old girl with breast pad and scanty pubic hair. So what about the Tanner stage? Here you go with the Tanner staging of the. This is the female breast changes, and this is the male genital changes. All right, and this is the pubic hair changes in both male and female. Starting with the breast, it is B for breast, so it is B1, B2, B3, B4, and B5. What is B1? B1, this is pre-pubertal, and B2 is the development of bud. This is the bud. This development of breast bud with elevation of the breast and papilla plus enlargement of the areola. A key stage of female puberty as it signifies the onset of puberty. So this B2 is important because it signifies the onset of puberty and it is the development of breast bud. B1 is pre-pubertal. When you get some contour in the breast, this contour in the breast, which is smooth, this is the juvenile contour, this is B3. And when the areola, the areola and papilla, they project above the breast, this area, this is B4. And B5, it is the adult with projection of the papilla, only as areola has recessed. The areola will recess. The contour, it becomes more adult-like. The areola, it will recess, and the papilla, it will project. Okay, so this is the B5 stage. This is the front view. This is pre-pubertal. This is development of the bud. That is the onset of puberty. Here you can see this contour. Then this breast, areola and papilla, they project above the breast. And this is more adult type breast, B5, which is the projection of the papilla only as areola has recessed. Okay, this is the adult type breast. Now coming towards the male genitalia, G for genitalia. So this is G1, G2, G3, G4, G5, G5. Okay. G1 is pre-pubertal. G2 is the enlargement of the scrotum and testes with reddening and change of the texture of the scrotal skin. All right. Enlargement of the scrotum and testes. Okay, the testicular volume, it is the first sign of enlargement of that is the testicular volume. It is the first sign of puberty. In the third stage, what happens? There is penile enlargement. First, the length, and then the further growth of the testes. Length of the penis becomes more, and further growth of the testes, they take place. What happens in the G4? There is increased breadth of the penis and development of the glands. All right, and darkening of the skin. Darkening and glands development, they happen in the fourth stage. And G5 is this is the adult genitalia. Contour and size and everything is that of adult genitalia. Now about the pubic hair. PH is for pubic hair. 1, 2, 3, 4, 5. Okay. PH1 is pre-pubertal, means no hair. There is no hair in both male and in female. In PH2, there is sparse. Sparse means little pigmented hair, and they are more straight. They are straight, long, straight, mainly along the labia or the base of the penis. This is the labia or the base of the penis. There is a straight, small pigmented hairs, which is the PH2, pubic hair, stage 2. Okay. 3, these hair becomes darker and coarser and curlier. They become curly. In 4, they become the adult type of hair, but covering a small area, not covering the lateral aspects. And when they cover the lateral aspects as well, near to the thigh, when they project towards the thigh, this becomes the pubic hair 5-stage, Tanner 5-stage, adult. This is in quantity and type, both adult type. Okay, so this is about Tanner staging. What they say in the first question, they say that breast bud is developed, breast pad, so it is B2. And about hair, they say that it is a scanty hair. So scanty hair is present in this 2-stage, second stage. Okay, first stage is no hair, second stage is scanty hair. Third stage is curlier and darker hair. Fourth stage is adult type hair, but covering a small area. And fifth is the hair that is projected laterally. Okay. So coming back towards the question. So staging was, it is breast stage 2, breast bud, and this is also 2. So this is correct. Okay, the first sign of puberty in male is the testicular enlargement. Okay, about 4 mm. They say an obese boy who is 12 years old, his testicular size is 2.5. So the first sign is the testicular enlargement, that is the volume of the testicle. And the first sign in female is, the first sign is development of breast bud, okay. And in male, it is the testicular enlargement. All right. This is in the male, and this is in the female. Next question is about the ambiguous genitalia. Ambiguous genitalia is a separate topic. Okay. But regarding the recalls, you can get 2 questions. And here they ask you about this decreased sodium and increased potassium. So this is very obvious scenario of CAH, congenital adrenal hyperplasia. All right, they presented with Shaw, and they asked you about the diagnostic test. So among the options, no cortisol, aldosterone, this is 17 hydroxy progesterone. All right. These topics need to be discussed in a bit detail. I will try to in the second session for this ambiguous genitalia and gender differentiation and precocious puberty. This should be discussed in the second session. Otherwise, it would take too much time. Let's proceed towards the next question. They say that a girl is with a type 1 diabetes mellitus and she is on basal and bolus regime of the insulin. What is the basal and what is the bolus? Basal is the long acting. I will write L, long acting insulin, which give you the constant stream of insulin. Okay? This is the long acting. Called is the basal regime. And bolus regime is the short acting insulin. I will write S. This is the short acting insulin that is given pre-meals or at the time of the meals to adjust your status with those levels at the time of the meal. So this girl is having type 1 diabetes mellitus and she is on basal and bolus regime. And her HbA1c is 7.9. What is the normal value of HbA1c? Let me show you a beautiful picture. And you won't forget it for the rest of the see this. So, see this beautiful picture. Below 5.6 is normal. Below 5.6. Actually, it is between 4 and 5.6. 4 to 5.6 is normal. This 5.7 to 6.4 is pre-diabetic, and above 6.5 is the diabetes. Above 6.5. In our scenario, it is 7.5. So it is the diabetic range. It indicates the poor control. The HbA1c, it gives you the control over the past 3 months. The glucose control over the past 3 months. I will show you another picture. This is below 5.7, 5.7 to 6.4, and above 6.4 is high. This is optimal, this is elevated, and this is low. Okay? So now coming back to our question. So this is the diabetic range. And mother found her in room. She is having convulsion and sweating. Actually, the question is quite simple, but there is too much information in the stem, so I thought I should elaborate each and everything. Look, there is one is that what are the different types of diabetes? I will be discussing it tomorrow. Second is the different regimes of bolus. Third, you just learn about the normal values of HbA1c and what is the HbA1c test. And what are the symptoms of, what are the signs and symptoms of hypoglycemia? Because patients who are using insulin, they can go into hypoglycemia. And you should know the signs that cold sweats and convulsions and confusion. These can be signs of low glucose. All this can be care. Let me also discuss the types of diabetes mellitus. You can see this table, classification of diabetes according to etiology. Okay? Etiology means this is type 1, type 2, and others. Others is also important. We will talk about that. Type 1 is the child with most cases of the diabetes, and it is due to destruction of the pancreatic beta cells by an autoimmune process. Autoimmune process, destruction of the pancreatic beta cells. Type 2 is the insulin resistance, which is followed by the beta cell failure, and it is present in the older children, obesity related and positive family history, not going to ketose. more common in some ethnic groups like the black and British. Okay, this ethnicity questions are important for task exam. They can ask you the ethnicity of the type is also important for both of the exam. What is the monogenic diabetes? Have you ever heard the name MOD? MO, maturity onset diabetes. All right, maturity onset diabetes of the young age. That is MOD, maturity onset diabetes of the young age. These are, they have a very strong family history and they give you a scenario in which there is the early presentation of signs and symptoms of the diabetes. And it is because of the gene, have to memorize the name of the gene, which is BDCC8. Let me confirm. Let me confirm. Yes, it is the ABCC8 gene and KCN channel. ABCC8 is the gene and KCN channel. This is for the task exam. Okay, KCN 11. This is called task exam. This is diabetes mellitus, which is called MELI, and they have very strong family history for the diabetes, and it's because of the transcription factors defect, genetic defect, and I have told you the gene names A, B, C, A, B, and okay, most of them it is a strong autosomal dominant. Also remember it is called autosomal dominant. This MODI is autosomal dominant. And what else? They most of the cases they do not require treatment. Rare causes they include associated with mutations in the mitochondrial DNA and maternally inherited diabetes or deafness syndrome, Kern's Spear syndrome, KEA RX, Kearns SAYRS, Kearns Spear syndrome, and those where insulin sensitivity is impaired by genetic defects in the insulin receptors signaling. Okay, so this is the maturity onset. So this is about the maturity onset diabetes mellitus. If you treat them, you give sulfonine medium. Okay. So what are the other types? One is the monogenic, others are the neonatal diabetes, which is transient or permanent, secondary to defective beta cell production, drug-induced secondary to corticosteroids, pancreatic insufficiency like in the cystic fibrosis and iron overload, in thalassemia and in endocrine disorders as Cushing's syndrome and gestational diabetes. Okay, this is about the types of the diabetes. So with one question I have covered so many. Type 1 is more common than type 2. What are the signs and symptoms of the diabetes? You can have polydipsia, polyuria, weight loss, and you can have a less commonly secondary aneurysms and skin infections can be. Yes, remember this picture of acanthosis nigricans. This dark skin in the axilla. This is called acanthosis nigricans, and it is a sign of insulin resistance. It's a type 2 diabetes. Yes, about the insulin. what are the different types of insulin? You can have the rapid acting insulin. Just remember these names for the task exam. Lispro, Aspart, and Glulisate. The onset of action is 15 to 20 minutes. Peak action is in the 1 to 2 hours, and duration is 3 to 6. Just remember this onset. Okay, short acting, rapid acting, then comes the short acting, Actrapid, which is given in, we discussed in the TKA, Actrapid. Okay, they give Actrapid, Humulin S and Actrapid. They have onset in 30 to 60 seconds. And then the long-acting Datamil, the Diprotec and Glargine. Remember, this is the exam important table. Whatever I'm covering is write exam important and write TAs. Task exam, okay? Once they asked, they have given options and they asked which one is the long-acting. And they have given all these options, and among them, Diprotec was the right option. Was it onset is in the 1 to 2 hour duration, and it lasts up to 24 hours. This is very important table. Whatever I'm covering is all is important. This is the basal bolus regime. This green one, this is the basal, and these small curves, these are the boluses. Okay. These are the boluses. Now, what happens with subcutaneous infusion? You can see this. All right. Diabetes is actually an important topic. That's why I'm covering it as much as I can. Yes, this kind of table you can find in the paper in which they have given you many readings. Okay, it's easy. It looks difficult, but actually it's easy. I will solve those recalls for you. Look here, this purple one is less than 4, which is the hypoglycemia. This one. This green one is with the target range. This green is all right, okay? And actually this red is more. So we have to manipulate the insulin where it is red. Where it is more, okay? Where it is more than 6.9 or 7, there you have to manipulate. I will show you the one table which is given in recalls, then you can easily understand. If it is uncontrolled, then you have to increase this. You give here, you give the short acting basal bolus insulin. Okay, you have to manipulate that. I will be solving with the recalls. Okay. Yes, about the hypoglycemia, how you treat a patient with the hypoglycemia. First of all, if the patient is GCS is more than 8, if GCS is more than 8, always go for the oral option. If the GCS is less than 8, then you can go for the IV option. And if you give IV and the glucose is below 14, okay, or you can say the patient is unconscious and the glucose levels are below 4. Remember this 4, okay? The glucose levels are below 4 and GCS is less than 8. Then you give IV 10% dextrose. 10% dextrose, 2 ml per kg. 2 ml per kg, okay? And if the patient's GCS is more than 8, and he is having glucose less than 14, then you go for the oral options. Oral, you first try giving the tablets, solids, okay, or gel. If glucose tablet or gel is in the option, always go first for that. If not, then you go for the sugary drink. Okay, glucosate is the generic name of this drink or tablet which is available. Actually, it is the gel. It is the gel which is available. Children should always have access to the hypo remedies. All the young children may complain of hypo symptoms. Okay, so a very good option is the glucogel because it is very quickly absorbed from the buccal mucosa, and it is very helpful if the child is unable to cooperate. You just put gel in their mouth and their hypo is corrected. It can be administered by the teachers at school or helpers. Next, you can offer them slowly absorb. After the treatment, you have to offer them biscuits or fruits, that is the slowly absorbed carbohydrate, to prevent the further episodes of hypo. And secondly, I told you that if they are unconscious, if the GCS is less than 8, it is mentioned in somewhere in the guidelines. If they haven't mentioned GCS here in the book, but I have read in the guidelines, if the child is unconscious and brought to the hospital, or unconscious means low GCS, then you have to assess IV and you give 10% glucose 2 ml per kg. So this is very simple now. You can get many questions from here in the SOP exam, and now you'll be able to solve. So what options I have given you, always first select the solids, and in the solids give glucose tablets or gel. If tablets or gel not available, then you can give sugary drink. Second is the liquid. Following this, you can give biscuits, you can give fruits after that, okay? And if the patient is having low GCS, then you can give this 2 ml per kg, IV 10% dextrose. Diabetic ketoacidosis I discussed in quite detail yesterday, and hopefully it is very clear by now. This is all repetition of those things which I have discussed. Okay, see, they have given the steps. They have given in a beautiful table. They say you assess the severity. And remember this, okay? Do not give bicarbonate to correct acidosis. This was discussed in one of my groups. You don't have to give bicarbonate according to these guidelines to correct this metabolic acidosis. First, you assess the severity, look at the pH, then the emergency measures, that is giving the bolus, antibiotics, etc. Third is the fluids, I have discussed in detail. Fourth is the insulin. Look here, 0.05 units per kg. You start with this UW, you can make it 0.1. And then you can drop it again to 0.05 depending on the levels. See the glucose less than 14. See the potassium, their values given in the 3 tables given in the guidelines. See the sodium, see the GCS, and then normalize. This is, I think, this is a very beautiful table. After those guidelines, this seems like a summary. Okay. Okay. Okay, let's go back to the points. Let me see anything else we can discuss here, so we don't have to open the book again. Hypoglycemia symptoms: sweating, pallor, irritability, headache, seizure, cough. Okay. Okay, let's go back. Yeah, please see one thing more. This is very important for the task exam. From where the insulin is coming? It is coming from the beta cells of the islets of Langerhans. This is the pancreas, okay? This pancreas and a chunk of pancreas is magnified. This in between, this portion is the beta cells. Outside is the delta cells, and most outside is the alpha cells. These blue are the delta cells, these orangish alpha, and this pink is the beta cells. Beta cells give insulin, alpha cells give the glucagon. Action of the glucagon is opposite to that of insulin, and delta cells give you somatostatin. It is a little information, but if you unable to memorize it, or if you forget this in paper, you will lose marks. So don't lose the marks, please. These are your solid marks. Just memorize this. Just make a rata and you will get your marks. Okay. Coming back towards the details, we have done so much about this diabetes and this hypoglycemia, this HbA1c, and the types of diabetes. Next question is about the thyroid. This is a 14-year-old girl who is hypothyroid due to autoimmune disease, that is the Hashimoto's thyroiditis. He is on levothyroxine 125 mcg. And she came to you with the high TSH and normal T4. Now look, this is a very interesting case. Okay? Look what happens. This girl, she is not having a good compliance of the drugs. And how I come to know this? Because if her T4, her TSH is high, this T4, it should be low. The feedback mechanism, if one is low, other is high. All right. So she has taken this thyroid just before coming to clinic. She's coming to my clinic and she has taken this levothyroxine. This levothyroxine she has taken just before coming into my clinic, and her T4 levels are normalized because she has taken this drug just right now. But her TSH is still high. Why high? Because it will take some time to normalize with this, okay? It will take some time. So time doesn't allow this. She came to my clinic. She is having poor compliance. She is not taking the drugs properly. And now I come to know. I caught her because she is cheating. She has taken this levothyroxine just now and she is not taking it on the daily basis. So I have to check her compliance with her schedule. Okay. This is a very famous question of top and task exam. Okay, this 14-year-old girl is deteriorated in school performance. This is one point. Decrease intelligence. Second is she is gaining weight. And third is she cannot do well in the gymnastic sessions and she's feeling tired. This is another symptom. Oligomenorrhea is the another symptoms. All symptoms go in favor of the hypothyroid. Because hypothyroid we have is decreased school performance, weight gain, constipation, oligomenorrhea, intolerance to cold, feeling tired. Okay? These are all the signs and symptoms of hypothyroid. Okay? Then another teenager girl who's active and playing gymnastics, she gained weight with decreased skill performance, and this will be again hypothyroidism. This and this, these both scenarios are similar. Okay, this question, I just figured that palpable gonads. Newborn has palpable gonads, but with the hypospadias. So what I was thinking, these two guys can also give this suggestion, that these hypospadias have some associations, and these associations are, okay, first of all, yes, what is the hypospadias? Let me introduce. This is the opening of the um, urethra under 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 this penis. It is not in front of the penis. It is under the underside of the penis. This opening of the urethra. This is called hypospadias, and there are several associations. One of my teacher told me that if you find one abnormality in a child, if you find one abnormality in the child, always look for the other abnormalities. Okay? He wanted to say always look for these samples. If you find one abnormality, suppose there is ear anomaly or suppose there is eye anomaly, start looking the whole body for the other. So I like this approach too much. And similarly, when I see hypospadias, I want to see the whole baby. And there are several associations in which I can find this, and the one which is written in the books is the Wilms tumor. In Wilms tumor, you can find in aniridia, you can find in genitourinary malformation, and a syndrome which is called Danny-Dresch syndrome. Danny-Dresch syndrome. So you have association of those hypospadias with this three or four conditions which I have mentioned. So if I say it is associated with hypospadia, associated with Wilms tumor, I go for the ultrasound. But this newborn, it is too early that we say this is the Wilms tumor. Yes, it can also have association with CAH. So that's why they have selected this 17 hydroxyprogesterone. They haven't gone for this karyotyping, although it can also see the correct option here. Serum electrolytes seems also correct, but straightforward selected this 17 hydroxyprogesterone just to diagnose this age. But they should at least have mentioned the age of the newborn in days, then selecting the option will be easy for us. So I must say that this is a poor recall, or it lacks some information on my behalf. You guys can also give me feedback if you better think some option is correct here and you think better than me. Then please also give me feedback. Okay, the next question is it is a 14-year-old girl who is having a weight loss and family history of diabetes. So it seems like a family history. Okay, this is obese girl, and the onset is not so early. She is obese as well. She has the weight loss. So first you need to diagnose either it is diabetes or either it is not. So the first thing you do is the random blood glucose, and the next thing you do is the C-peptide to differentiate type 1 and type 2 diabetes mellitus. Anti-GAD autoantibodies are more specific for anti-GAD, are specific for the type 1. And the C-peptide, it is used to differentiate between 1 and 2, which is specific for the cancer. Okay, but first you need to know either this is diabetes or not, so go for the first option. Okay, this is the question of hypoglycemia. I just discussed hypoglycemia. 11-year-old child is diabetic, and he is visiting his sister in the hospital, and mother found him shaking. He is shaking, means he is having this hypoglycemia. She measured the random blood sugar, and it is less than 4. that is 2.5. Okay, or you can say it is less than 6. What is the best action? So the best action, if you find in the option, is glucose tablets. First offer the solids, then go for the liquids. Glucose tablets, then the gel, then the sugary fluid. Okay. Followed by this, you can offer a piece of biscuit or a bar of chocolate. Glucagon is wrong here because it is later step. Toast you can offer later on. Okay, let me show you one thing more. This is the hypoglycemia guidelines. I just wanted to show you very little. They say that if GCS is less than 8, then obtain IVSS and give 10% glucose 2 ml per kg bolus, followed by infusion of this 10% glucose with sodium chloride. Okay. Sodium enhances the absorption of glucose. They both, when given together, they enhances the absorption of each other. And if GCS is more, like it is more than 8, then you have to investigate for the cause and do feed the solids. Always go for the solids first. If he's not interested in the solids, like the tablet, you can offer this glucogel, glucosate flat, or the glucogel. And if not this, there is written a sentence in the TKA guidelines. And the sentence is, when blood glucose it is less than 14 millimole per liter, use a glucose containing fluid. I will show you that sentence. I have highlighted in my book. I will show you that. I will share. So here the option sugary fluid is a better option for us. This is the better option. Okay. Okay, DK scenario. What is the initial maintenance? Of course, 0.9% sodium chloride, 500 ml with 20 millimole KCl added. This one, okay? This we did yesterday. Okay, yes, now coming towards this question. Actually, this is easy. This is not so hard. They say that patient takes long acting in the night, which is 20 international unit, and 1 unit she take before breakfast for the 8 gram of carbohydrates, and 1 unit before the lunch, which is 10 gram for 10 gram of carbohydrates, and 1 unit in the evening, which is for the 10 grams of carbohydrates. Okay. So we give pre-breakfast, pre-lunch, pre-dinner, and bedtime. Just mark or underline whatever is more than 7. Yes. Post lunch, it is more than 7. 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 This is more than 7. Means it is uncontrolled. Okay. These all is uncontrolled. Okay. This is fine. This is fine. This is fine. This is fine. So where it is not balanced, where is the problem? Look, it is post lunch. The problem is post lunch. The problem is this with dinner. Pre-dinner means in between the lunch and dinner, and post-dinner levels are also high at the night. So what information I gather is that I have to manipulate this pre-lunch and this pre-dinner doses. I have to increase the insulin here and here. Got it? This is easy. These are the short acting lunch and dinner. When will you manipulate this bedtime? When the morning levels are not normal. We will discuss Somogai effect in a while, in which there is rebound hyperglycemia. Rebound hyperglycemia. Actually, what happens? You give too much long-acting insulin in the night, so the patient got hypo around 2 a.m. or 3 a.m. in the night. And secondary to that hypoglycemia, the natural body mechanism, the body go into rebound hyperglycemia. And in the morning, when the patient wakes up, he wakes up with too high levels of glucose because you are giving too much insulin. So you have to cut down that long-acting insulin which you give at the bedtime. You have to decrease the dose of that. Okay, and this effect is called the Somogai effect. Yes, there is a beautiful table for this. I will show. I always detected this vitamin D deficiency by just looking at this very high alkaline phosphatase. Alkaline phosphatase, whenever it is high, this is always vitamin D deficiency. Okay. Low calcium and phosphate is low with this deficiency, and secondary to this low calcium and phosphate, this parathyroid hormone, it becomes high as a result of the feedback mechanism. All right, I am going to show you table in a while. Okay, so which book it was in? I think it's in SOP. Let me share. Hopefully I find it. Wait, not in the SOP. Then it must be in the. Okay, wait, let me check in the hard copy because I I used to study from this hard copy. I never used this hard copy, but I'll listen for you guys. Okay, it's in the illustrated. Okay, some things we need to see from the illustrated, and some things we need to see from the SOP. I found this book illustrated very good for FOP exam, and SOP it is very good for the TAS exam. Yes, here it is, this table. I like this table so much. You will like it too. Just see what happens in the vitamin D deficiency, what is the primary hypoparathyroid, what is the pseudo hypoparathyroidism, and what is the primary hyperthyroidism. Only one condition where calcium is increased is the primary hyperparathyroidism. Here phosphate is decreased. Alkaline phosphatase is always normal except for this vitamin D deficiency. And parathyroid is high. Parathyroid is too much high in hyperparathyroidism. It is too much low in the hypoparathyroidism, and the calcium, the phosphate, it is increased and it is decreased in the primary hypoparathyroidism. It is decreased and increased, same pattern as primary and pseudo, but this parathyroid can be normal or high instead of low. Okay. So this is actually a very beautiful table, and this do so much for you, this table. I used only this table for my exams. Okay, next question. This is a girl who is 14 years and her length is 147 centimeter and mother is 162 centimeter. She asks if she will be as tall as her mom. So what will you say? Actually, the final height it depends upon the growth spurt that occurs at the time of puberty. That occurs at the time of puberty. Growth spurt that occurs at the time of puberty. And what is the tenor stage of the puberty? It is in the female, it is the development of breast buds. So her height at this stage defines her final height. Whether she will be like her mom or not, we can just guess from this spurt which happens at this puberty. Okay, so this option is correct. This is how I explain it. Okay, this is about the ambiguous genitalia and family wants to give name. No, no, you cannot assign name before the investigations. Do not assign name, okay? Wait for chromosomal results can also seem the correct option, but here it's not written that do not assign name. So you do not assign name and wait for the full investigation results, okay? Karyotyping or hormone levels, whatever is awaited, just wait for it. Okay, now coming towards this question. This is the extended matching question, and a patient with diabetes mellitus has vomiting and nausea, but RBS is absolutely normal. So you don't have to change the dose of the insulin, but you have to offer the oral fluids. Even you can offer the sugary fluids. Why? Because the disease condition, body goes into stress and it is needing more glucose, but you continue the same dose of insulin. Okay. This second scenario, 14-year-old girl who has morning hyperglycemia. RBS at about 2 a.m. is very low, and in the 10 a.m. it is very high. This is actually the Somo guy effect. Somo guy effect. So you decrease the long-acting insulin which you give at the bedtime. You decrease that. Please don't forget this is very important scenario. Okay, a patient with the diabetes mellitus vomited once. He has abdominal pain and ketones. This is DKA. RBS is very high. So you give short acting, not extra short. It is the Actrafid, which is a short acting. Actually, short acting insulin, it is not in the options. That's why they have selected extra short. Look, this is not in the option. Okay. So, a diabetes mellitus patients developed hypoglycemia after playing match in this school and did the RBS and called you to tell that it's low, it's 2 millimole. What advice you give? Offer glucose tablet, but glucose tablet is not always available at school or at a playground, but juice can be available. So give a cup of juice, that is the sugary drink. All right. Okay, this is with the palpitation and tremor at 6 weeks. TSH is 0.02. TSH is low. T3 and T4 are high. This is a case of hyperthyroidism, a suspected case of hyperthyroidism. And UK guidelines, they haven't given this hyperthyroidism guidelines in their blue book. So from what I actually concluded, that UK system, they always want pediatricians to refer this hyperthyroid patients to endocrine clinics and let them deal these cases only by the endocrinologist. But you have to send them in the 2 weeks. Why 2 weeks? So that we can repeat this report of the thyroid function test, and we can compare the two readings and we comment, and if we want to commence the treatment, at least we have two readings to commence the treatment. Okay, so better you send. Next question is, with the irregular cycle, hirsutism and dark pigmentation. This hirsutism, irregular cycle, dark pigmentation, it is the polycystic ovarian syndrome, PCOS. Okay. Okay. Patient was diagnosed with diabetes mellitus and his sugar level were controlled for 5 years now. Father has hypertension. What is the most important? Okay, if the father is hypertensive, mostly hypertensive people, there is association of diabetes as well with this hypertension. So might seems like he is having this family history, and he is having this type 1 diabetes mellitus, which runs in the family. Okay, so his sugar levels are controlled, but this is type 1 diabetes mellitus. So for type 1, he's not producing insulin from his own, so he will be needing insulin for the rest of his life for this better management. Okay, the next question, it is about a 13-year-old patient who is on 50th centile for weight. Okay, 50th. And 75th for height. Height is more, okay? Height is more, weight is okay. She is not growing for the last 2 years. For the last 2 years, her growth is stopped, or we can say she is now not thriving. Mid-parental height is not given in the question. Mid-parental height I will be discussing in my next section. This is having significance regarding whenever you approach a short stature or a long stature patient, you have to see either this comes from the family or not. So you take a mean of both father and mother height, and this is called the mid-parental height. You say that her school performance is acceptable and tenor staging at the age of 13 years is P3, P3. This is also acceptable. If her puberty is acceptable, school performance is acceptable, means TFT is excluded. Tenor staging is acceptable, LHFSH is excluded. There is no anomalous, no features that point towards any chromosomal anomalies. So this is out. This is also out. You have to see between this anti-tissue transglutaminase, IgA antibodies or IgF. Insulin-like, either you have to see for the insulin-like growth factors or anti-transglutaminase IgA antibodies. They haven't given any abdominal symptoms, so I want to go with this insulin-like growth factors. Okay, yes, ma'am. Okay, there is a syndrome which is called Beckwith-Whitman syndrome. Where Beckwith-Whitman syndrome, remember large tongue and hypoglycemia. Remember these two things. They say they have the ear crease and they have decreased weight. 12% weight is now 4.1. So you do the blood glucose because they are more prone to the hypoglycemia. Okay. Okay, polyuria, polydipsia, weight loss. It is a case of diabetes mellitus 2 RBS. Okay, rest of the questions I will be recording in the morning, inshallah. And that diabetes insipidus, nephrogenic and central, that I will cover with the nephrology section. and the rest we will be discussing this precocious puberty and um, about this ambiguous genitalia. Okay, so the records which are left, those along with the task records, I will post in the morning, inshallah. Okay? Good night and take good care of yourself. I hope you understood today's lesson. Take care, dear doctor. Allah Hafiz.